Good morning, everybody. Colorectal cancer is the third most common cancer diagnosed in both men and women in the United States. And joining us today are Dr. Kelsey Clutie, a Nebraska Medicine medical oncologist, and Dr. Jennifer Leineke, a Nebraska Medicine colon and rectal surgeon. Thanks for joining us, ladies.
Hi.
Thanks for having us.
So first off, just what is colorectal cancer?
So colorectal cancer is a type of cancer that starts on the inside lining of the colon or rectum. So the colon and rectum is you can basically think of it as a long muscular tube. So cancers that start in the colon tend to start on the inside lining of the colon. And what a cancer is basically when the healthy cells in any part of your body kind of develop an abnormal ability to grow and also to the possibility of spread. So in colorectal cancer, you have this muscular tube, and cancers is just abnormal growth of cells on the inside lining of that tube that if they aren't addressed early, they can kind of start to grow through the wall of that tube. This kind of leads into a question about screening, but that's why colonoscopy can be so helpful in detecting these cancers early, is that you can go into the inside of the tube and you can see these early growths of cells before they even become cancers.
Well, you mentioned screening, so who should get screened for colorectal cancer and when?
So like Dr. Clutie alluded to, colorectal cancer screening is really important because when you have a colonoscopy, we're not only able to diagnose a cancer, but hopefully we prevent cancers by taking out polyps, which are early abnormal growths that have the potential to become cancers over time. The general screening recommendations are for patients with average risk, so no family history of colon cancer or rectal cancer, and no medical conditions that would otherwise predispose you to colon cancer, such as inflammatory bowel diseases. For most people, that starts at age 50, or if you're an African American, you would start screening at age 45. If you have a family history of colon cancer, as in a first-degree relative, so a brother, a sister, a mother, a father that has colon cancer, or there are multiple people in your family, so your father and several of his brothers or sisters, or your mother and grandmother, so a significant family history, those people are going to want to get screened 10 years prior to when their family member was diagnosed. So if your family member was diagnosed at age 50, then you should start getting a screening colonoscopy at age 40.
Okay. Well, other than getting screened, what are some other things that people can do to help prevent colorectal cancer?
So things that we think help to reduce somebody's risk of developing colorectal cancer are maintaining a healthy body weight, so avoiding obesity, eating a healthy diet, and really what does that mean? It's hard to say exactly, but a diet rich in fruits and vegetables probably offers some protection against developing colon and rectal cancer. Regular exercise, and then also just kind of following up with screening guidelines, so which a primary care doctor can usually do a pretty good job of keeping tabs on. But also if somebody develops any symptoms that are suggestive of the possibility of colon cancer, to get them kind of addressed or see a physician about it right away. So things like blood in the stool, change in bowel habits, so less frequent bowel movements, more frequent bowel movements, a change in the size of the stool, any kind of changes in your bowel habits, abdominal pain, can be signs of an early colon cancer that if, addressed early, you may not be able to prevent the cancer, but catching it early can make it much easier to treat and cure a colon cancer.
So once someone's diagnosed with colon cancer, what treatment options do we offer patients here at Nebraska Medicine?
So the treatment for colon cancer depends on what stage you're diagnosed at. And here at Nebraska Medicine, we have a full range of specialists that we're able to offer all of the different treatment options for colon and rectal cancer. So typically for colon cancer, as long as it hasn't spread to other areas of the body, the first step is surgery. As a surgeon, I do the majority of my surgeries for colon cancer and rectal cancer, either laparoscopically or robotically, so minimally invasive with small incisions. For rectal cancer, the treatment is a little bit different because sometimes people need some chemotherapy and radiation therapy before surgery. And then depending on what the final pathology or what your final tumor looks like after we take it out is whether or not you need to get some additional treatment after surgery.
And for cancers that have spread beyond the colon at the time of diagnosis, the treatment becomes a little bit more complicated. Colon and rectal cancers tend to most commonly spread to the liver and to the lungs. So if you have a cancer that's spread outside the colon, a lot of times the first step in treatment is chemotherapy, so using drugs to treat the cancer, because that addresses the cancer in the colon, can address the cancer in other organs, as well as any microscopic cancer we may not be able to see on a scan. Colorectal cancer is a little bit unique in that even in some cases where the cancer has spread outside of the colon or rectum, there is still an opportunity to cure many of those patients. So I'm talking about stage 4 colorectal cancer. In a lot of other diseases, stage 4 cancers are considered to be incurable, and so any treatment is done to slow the progression of the disease. But in colorectal cancer, there is still an opportunity for the possibility of cure in select patients with metastatic or stage 4 disease.
Okay. What about clinical trials? Do we offer those for patients here at Nebraska Medicine?
So we have the big clinical trial that comes to my mind is a clinical trial looking at changing the treatment of some patients with rectal cancer. And so what we're looking at is, can you eliminate the need for radiation in certain patients with rectal cancer? We also have a clinical trial for patients with more advanced disease that looks for specific mutations within a cancer, a colorectal cancer. And if we find something that we have a drug for, we can use that drug as part of the trial to target that mutation. There's also a lot of growing evidence about the use of immunotherapy for patients with colorectal cancer. And so we're looking to open a couple clinical trials that are using immune type therapies in select patients with colorectal cancer.
That's exciting stuff. So bottom line, why should someone come to Nebraska Medicine to be treated for colorectal cancer?
Nebraska Medicine offers the opportunity to be seen by a wide range of specialists who only treat GI and colon and rectal cancers, whether that's radiation oncologists that only do that, whether that's medical oncologists that only do that, or whether that's surgeons like myself who only treat diseases of the colon and rectum. Additionally, a lot of patients don't have the most straightforward medical conditions, and so our academic medical center allows us to take care of the sickest of the sick and the people that have the most complicated medical problems, because we also have such outstanding support in the intensive care unit and with other consulting specialties.
Yeah, we have a really great multidisciplinary team that takes care of cancers of the gastrointestinal tract, and we meet weekly to discuss cases that aren't so straightforward. And I think, that's somewhat unique in that we work together all the time. Our pathologists, our radiologists are, very specialized. And so if there's any kind of question about a diagnosis or management, we have a nice team. You can get several opinions with one stop, because a lot of times we've discussed a case with our entire team before a patient even meets one doctor from our team.
So bottom line, for those who are newly diagnosed, what's the one piece of advice that you guys really want them to take away from your chat today?
I think the most important thing to take away from this is that colon and rectal cancer is unfortunately really common, but it's also very, very treatable, and for a large number of patients, we're able to cure their disease. Even in the patients that we aren't able to cure, we're able to give them a good quality of life for a pretty long period of time.
Mm-hmm.
And by being taken care of by specialists, that offers you the opportunity to be cared for by people that only take care of your specific problem, as well as the opportunity to potentially be enrolled in various clinical trials that aren't being done in other areas of the city.
I think another important thing just for individuals to remember is just in terms of early detection and screening, that catching a cancer early, either because of symptoms that have recently come on or through screening, is really the best way to improve outcomes, prevent a patient from developing a cancer, or addressing it early and reducing the chance that cancer actually threatens their life. And so keeping up to date with colorectal cancer screening, as well as seeking medical attention if there are any changes that we talked about earlier. I think, especially in young people tend to ignore these things because they think, it's probably a hemorrhoid or it's probably my diet. But, if these things can be addressed early, a lot of times we can catch a cancer while it's still very easily treatable. And so not ignoring symptoms related to your abdomen or bowel habits, because, it can be somewhat embarrassing, or, it's not something you want to talk about. But the thing to remember is we talk about this stuff every day. Primary doctors see patients with these complaints every day. And so the most important thing is just seeking medical attention for it early on, because that can really change how much treatment a patient needs and kind of the likelihood of curing an early cancer.
And Dr. Kluge, you kind of touched on it a little bit, but you guys are seeing more young people coming in with colon cancer, correct?
Yeah, there's a kind of a increasing incidence of colorectal cancer in people under the age of 50, and nobody quite understands why. It's not so common that we think screening all patients, earlier would make sense. But certainly, the thing to remember is just because you're not 50, it doesn't mean you can't get colon cancer, and it doesn't mean a colonoscopy wouldn't be recommended or covered by insurance. So if somebody is having symptoms, typically insurance would cover a colonoscopy. And we still think that catching these cancers early is the best way to kind of improve the outcomes for these younger patients who are getting colorectal cancer.
And additionally, when you screen someone with a colonoscopy, even if you don't find a cancer, a lot of the time we find these polyps that are the precancerous cells that we're able to remove and thereby prevent you from getting colon cancers. So we've actually seen over the last kind of 5 to 10 years an overall decrease in the number of colon cancers that are being diagnosed, which we think is attributable to people getting screened more regularly and following up with screening guidelines. So while most cancers are diagnosed in older adults, that overall incidence, so number of people that are getting diagnosed with colon cancer in the older population has been slowly declining over the last 10 years because of our screening efforts.
Susan on Facebook has a question. If you have a family history of colorectal cancer, how often should you get a colonoscopy?
So it depends on what your family history is and whether you've been diagnosed with a specific genetic defect that is causing that type of cancer. But generally, if you have a family history of cancer and no known genetic cause for why people in your family have colon cancer, to start getting screened 10 years before that person in your family was diagnosed. So again, if your family member was diagnosed at 55, you should get a colonoscopy at 45. If they were diagnosed at 45, you should get a colonoscopy at 35.
And the frequency of screening really depends on the reason for early screening. So like you mentioned, whether there's a genetic problem that increases somebody's risk of colon cancer, those patients are typically screened much more frequently. But for most people, the frequency of screening depends a lot on what you find on the colonoscopy. So if they remove polyps, typically they recommend earlier screening. If the colonoscopy looks perfectly clear, a lot of times the recommendation is to have another colonoscopy in the next 10 years.
All right. Is there anything else you guys would like to add?
I don't think so. I think we covered it.
Well, if you guys have any other questions, just submit them on our Facebook page, and we'll send them to Dr. Clutie and Dr. Leineke and get you guys some answers. So thank you, ladies, for joining us.
Thank you.